Hello, I'm Dr. Robert Lelouch, a board-certified OB/GYN physician with over 30 years of clinical experience. Today we're going to talk about what are some of the common indications for cesarean section once you're in labor. Now, I do have a separate video on emergency cesarean sections, and you might already have a planned scheduled C-sections, perhaps just because you've had one before, but we're going to go over some of the reasons why you come into labor or you're being induced and you're in labor, and then something changes and we tell you that the best choice is a cesarean section. So one of those, the most common, is the baby's not coming down or labor dystocia or not fitting. So there is a natural progression of labor, what we call the latent phase and the active phase. The latent phase used to be considered until you got to 4 centimeters, but more recently it's been changed to 6 centimeters in an effort to reduce the C-section rate, to give a little bit more wiggle time, because it can take 12 to 24 hours for you to be in the latent phase to get to that 4 to 6 range. More closer to 12 hours if it's your second baby, and more up to 24 hours if it's your first baby. So that amount of time is considered, if you exceed that time, a prolonged latent phase. But if you have good understanding of what's going on and everything else is going well, that is only kind of a signpost for you to consider, for your doctor to consider maybe you need a C-section, or have reasons to say, well, we think there's good justification to go on, like your cervix wasn't favorable, or you weren't on medications. There are a variety of reasons. Okay, so if you have that prolonged latent phase or you have a prolonged active phase, and that's generally, we want to see you progressing a centimeter to a centimeter and a half every hour. Once you're in the active phase, that means getting from 4 to 6 centimeters all the way to complete, and then about 2 hours to push the baby out if you've had babies before, and about 3 hours to push the baby out if it's your first baby. So once you exceed those numbers, then that again is not a line in the sand, but more of a signpost that says, evaluate what's going on. Is the baby fitting? Is it too big? Is the pelvis too small? Is the baby's position not helping the matter? So for example, if the baby is OP, occiput posterior, that means it's laying on its back with its face to the sun. That increases the chance for it to be delayed. And for example, if you're fully dilated or near so, and the baby is laying that way, there may be the opportunity for your physician to turn the baby if they are learned in that skill. But if everything else is going well, then, and there's a good analysis, you might decide to proceed on. If there's a little bit of concern with the baby's heart racing, or let's say there's meconium. So meconium is when the baby has a bowel movement and then the fluid is dark. That by itself is an indication for a cesarean alone. However, just because of the meconium doesn't mean that your physician would tell you that you need a cesarean. However, if you have meconium and you're proceeding slowly, or you've been pushing for a while, you're not making progress, that's when all the risks start mounting, and where the decision to recommend a cesarean section becomes appropriate. These are general guidelines. You're an individual, your labor is an individual situation, and other than the emergency circumstances, there are times when we feel the data suggests, the studies suggest, that doing a C-section will result in a lower risk to you and your baby and a better outcome. Now, having a baby has a risks vaginally, and having a baby by cesarean has risks as well, and we weigh those risks, and when the risk of continuing to try to attempt vaginal is higher than the risk of proceeding a C-section, that's when we offer it. But those risks are not so vastly different that, in fact, over the last few years, I would say about 10, maybe 15 years, we've even gotten the risk down for cesarean section sufficient enough that you can just electively decide you want a C-section. You can just say at any time, I don't want to have a vaginal delivery, I want a C-section. Now, we encourage you to have a vaginal delivery because a successful vaginal delivery has a little less risk of injury to you, infection to you, a little less risk to the baby overall. So we highly recommend that you go with a vaginal delivery, but that difference isn't so great that it isn't an option for you. Another reason that we might recommend a cesarean section is fetal malposition. So the baby's in the wrong position. We talked about the occiput posterior, but sometimes you come into labor, you start to progress, and then we realize that the baby is breech. Now, we try to catch that beforehand. We check you around 36 weeks. We check you on exam, but if you're not too dilated or there are other circumstances where it's not quite clear, so often when we do inductions, we do an ultrasound before to verify the baby's position. But if you've had many babies before, I've even seen it change position. Once your bag of water is broken, pretty much not going to happen. But before that happens, they can change. But again, having a good, well, that's a reason is the baby's in the wrong position. Breech, where C-sections are much safer than a breech delivery, which might require some special forceps called Piper forceps, and the baby's body's a little smaller than the head and it can get entrapped, and that's why the outcomes are so much better for C-section than breech, that we generally don't do breeches anymore. There are exceptions to that, but that's the general plan to proceed if the baby's malpositioned that way. There's also something called a shoulder dystocia where the baby gets stuck, but that's more of an acute circumstance, and that's in the emergency C-section. You might have an infection that evolves, so you get a fever and you're not progressing well, and then you get your heart racing and the baby's heart racing, and that can make you and the baby exhausted, and if you're not progressing fast enough, that can be an indication for a cesarean section. Or sometimes there's what we call a non-reassuring fetal heart rate tracing, and that's where the fetal heart rate is a way of us assessing the baby's well-being. There are patterns, the heart accelerations, there are decelerations. It might mean that the cord is getting pinched or entrapped. It might mean that there's a problem with the placenta. It's an indirect test. It doesn't tell us everything, but if you have a non-reassuring fetal heart tracing, that might be a reason for us to say, look, we're very concerned for the baby's well-being and we think it's safer to do a C-section. And there are different levels of non-reassuring, and if it's really non-reassuring and the baby needs to come out quickly, again, that's covered in the emergency cesarean section. But we take all of those puzzle pieces together. How fast you're progressing, what is the estimate of the size of the baby compared to your size, the size of your pelvis. For example, in some studies that show that if you are under 5 feet tall, you have a risk of a cesarean section as high as 50%. Depends on your heritage as well, and also some of the influence is how big is the baby relative to you. There are some studies that suggest the size of the baby is dependent on your weight before you were pregnant and the weight and the height of the father of the baby. But none of that is definitive, and even an ultrasound can be off by 1.5 pounds, so we don't have an exact way to know the size of the baby. We factor in all of the information. The chance of issues going awry increases as you become post-8s the further along you get, or if you're preterm or earlier. Blood pressure issues, if that's progressing and you're not progressing, but your high blood pressure pregnancy problem is getting really severe, might be an issue that's factored in deciding on cesarean section. If it's not emergency C-section, and if you want to hear about that, watch that video, then often we can use the epidural or spinal. That way you get to be awake, your partner can come back there with you, there's some time to get it done, and still have a wonderful, intimate experience. So I hope this general information has been useful to you, and would love to hear your comments. Thank you.